Hello. So today I've seen a patient, let's say name them patient A, came in with community-acquired pneumonia and developed type 2 respiratory failure where there's buildup of carbon dioxide and leading to acidosis. And there was decision made to put this patient on NIV, which is non-invasive ventilation, to help with the ventilation and washout of carbon dioxide. Patient was started on the NIV, and usually within 1 hour of putting a patient on NIV, you would look for signs of reversal of carbon dioxide and normalizing of the pH, or at least to the road to recovery. But this was not happening. There was static blood gases initially, and over a period of time, which is another hour or so, there was worsening of the carbon dioxide accumulation. So this is officially a NIV failure, and then decision was made to intubate this patient. This patient has quite high BMI, a short neck. It was difficult to intubate this patient. It's grade 3 intubation, and the vocal cords, the view was quite anterior. So there are certain criteria when you say difficult intubations and levels of intubation. So we'll discuss about that in the video coming about. This was a difficult intubation, and sizes of trachea, again, ET tubes are different, and this patient had a size 7 ET tube. Once they extubated, the ventilator requirement was quite high as well. And they've done a CTPA. So CTPA is CT pulmonary angiogram to look for any pulmonary, any PE, which is pulmonary embolus. And there is some segmental PE for which the patient was started on therapeutic enoxaparin. And in this patient, I've also inserted a central venous catheter where the registrar supervised me. I'll do another video, because it was quite an interesting procedure as well for this patient on high ventilator requirement of vasopressor support. So the main problem here was ventilation. Also because of the background of high BMI and obstructive sleep apnea, which was suspected previously because of prolonged snoring, as per the family has told. Something tipped over and this patient landed up in type 2 respiratory failure. Now the blood gases have normalized, but the problem is this patient's saturations on the pulse oximetry is 100%, but on the blood gas, the PaO2, that is partial pressure of oxygen, is only 7 kilopascals, but the pH is normalized. We've had a look at the methemoglobin and carboxyhemoglobin, which could explain some of the reason why there's a mismatch between saturations on the probe and blood gas oxygen, that is hypoxemia in the blood. The pulmonary embolism as such can also contribute to ventilation perfusion mismatch, because the blood vessel is obstructed. So you have dead space wherein the alveoli is ventilated, but there is no perfusion to that. So it's technically a dead space, and this could contribute to the mismatch as well. It was also desaturating quite a bit, and the chest X-ray showed large areas of consolidation, which was keeping in with mucus plugging, and there were a lot of secretions as well on suctioning. So they bronched this patient twice already and sent these samples for culture. One of the samples have come back negative, which is no growth. But I was told that bronchoscopy the cultures which we send can only grow certain types of bugs, and about 60% of times they might not pick up the bug which we are looking for. And because of desaturation, high ventilator requirement, in spite of FiO2 being 100%, we're not able to go up on the PaO2 in the blood gas because of mucus plugging and poor ventilation. This patient was proned. So you can check PaO2 by FiO2 ratio before proning a patient, which is officially classifying patient as ARDS, which is acute respiratory distress syndrome. And we've started this patient on lung protective ventilation, wherein there are targets for P plateau of less than 30, driving pressure of less than 20, and your tidal volume 6 to 8 mils per kg based on the ideal body weight. Here we think about ideal body weight and not the estimated or total body weight, because your lung function depends upon your height and not your weight. So, and your ideal body weight takes into account your height. So that's how you calculate the tidal volumes, and make sure you put your IPAP and EPAP to achieve your tidal volumes. And yeah, so currently patient has had one session of proning and FiO2 requirement has improved, and tidal volumes are doing good. And before proning, you would make sure they are well sedated. You paralyze them. Here we give rocuronium, which is a paralytic agent, before you prone the patient. And yeah, patient is doing good as of now, and I'll keep you updated.